Hi, my name is John Guzik, and I'm a hospitalist at Moses Taylor Hospital in Scranton, Pennsylvania. Today we're going to talk about the CMS core measure for treatment of patients with severe sepsis and septic shock, and the role of the emergency medicine provider in providing standard of care treatment to patients with severe sepsis and septic shock. We are today going to cover the definitions of sepsis and severe sepsis. We're going to talk about the elements of the sepsis core measure and where those elements come from. We're going to talk about the denominator of the core measure, mainly, in other words, who is included in the core measure. And then finally, we're going to talk about the barriers to successful provision of standard of care treatment for these patients and lessons learned that we've gained from our experience at Moses Taylor Hospital. What we're not going to talk about so much today is the treatment of septic shock. We're not going to be speaking about the difference between early goal-directed therapy and the process trial, for example. The talk today is going to deal primarily with treatment, with identification of and treatment of patients with severe sepsis and septic shock in the emergency department particularly. So very, very briefly, we're going to talk about the scope of the problem in the U.S. We all know that there are 500 to 1,000 patients every day in the U.S. that die from sepsis and severe sepsis and septic shock. We know that inappropriate treatment, such as inappropriate antibiotics or inadequate fluid, increases mortality. And we also know that multi-center trials that look at the 7 elements that are included in the CMS core measure show that the greater number of elements that a hospital implements in the care of patients results in a progressively lower mortality for those patients. So let's get into the definitions because only about 17% of physicians actually, in some studies, agree that there is a firm definition for severe sepsis. So the core measure is based upon the definition of sepsis, which in turn is based upon the definition of SIRS. The core measure definition of systemic inflammatory response syndrome uses the classical criteria, the 4 criteria that were published by Sir Roger Bones at the Clinical Consensus Conference by the NIH back in the early 90s. Those 4 criteria include a temperature greater than 101 or less than 96.8, a heart rate greater than 90, respiratory rate greater than 20, and a white count greater than 12,000, less than 4,000, or greater than 10% immature forms. If 2 of the 4 classical SIRS criteria are present, then the patient meets SIRS criteria. In your emergency department, only about 50% of patients who meet SIRS criteria will actually have sepsis. Sepsis is the clinical syndrome that results when SIRS is due to an infection. As we all know, SIRS can be present in patients with anxiety who might have a high respiratory rate and a high heart rate, patients who have paroxysmal rapid atrial fibrillation, patients who have a seizure, for example. None of those patients have sepsis. They would have non-infectious SIRS, and we want you to use that word in your impression, non-infectious SIRS. We also would like you to use the word sepsis when it's appropriate. If you see SIRS with an infection, rather than saying SIRS plus UTI, we would like you to say sepsis due to urinary tract infection in your impression. The core measure does not include patients with simple uncomplicated sepsis, because the mortality rate for patients with sepsis is not affected, is not high, and it's not affected. It's not been shown to be affected by early treatment. Positive blood cultures, as we know, does not equate with sepsis. The word bacteremia means that there are bacteria that grow out of the bloodstream, but we've all seen patients who have bacteremia who don't have clinical sepsis. They may not have a high respiratory rate or an elevated temperature or a high white count. They may be completely asymptomatic and yet have bacteremia. So bacteremia and sepsis are not the same. Now, let's talk about the patients who are included in the core measure, those patients with severe sepsis and septic shock. So, severe sepsis is defined as patients who have sepsis but also have end organ damage. And that end organ damage can include liver damage, elevated liver function test, bilirubin greater than 2, acute renal failure, creatinine greater than 2, or a single episode of hypotension, blood pressure systolic less than 90, mean arterial blood pressure less than 65, or other evidence of clinical hypoperfusion. Septic shock, on the other hand, means persistent hypotension after a 30 cc's per kilogram bolus of crystalloid, or evidence of extremely critical hypoperfusion, as demonstrated by a lactate of 4 or greater. The core measure will include patients who have an infection when you say sepsis and they have end organ damage. But even if a patient does not meet criteria for severe sepsis or for septic shock, if you use the word septic shock or severe sepsis, then you're including that patient in the core measure. And if you say septic shock, even if the patient doesn't have that, you will have to meet most 6 or 7 of the elements that are required for the patients with septic shock in your documentation. So just to review, of the patients that are going to show up in your emergency department who are screened in triage and have a positive sepsis screen, they have two of the 4 classical SIRS criteria. Half of them will have non-infectious SIRS and only half will have sepsis. But even of the septic patients, only half have severe sepsis. And the severe sepsis patients are the ones that are included. The patients with septic shock are a very small number, perhaps only 10% of the patients with severe sepsis. And so, in general, this talk is going to focus primarily on the patients with severe sepsis. So, again, we're going to review the patients. We're going to talk about the four definitions: SIRS, sepsis, severe sepsis, and septic shock. But patients with sepsis are not included in the core measure. Patients with sepsis don't need fluids. They don't need repeat lactates. Only patients with severe sepsis and septic shock are included in the core measure. And when the patients have severe sepsis or septic shock, we'd like you to say severe sepsis due to pneumonia, septic shock due to urinary tract infection in your impressions. So you're clear yourself on what the requirements are going to be, and so you can make sure that that patient is included. Okay, so we've talked about the definitions of SIRS, sepsis, severe sepsis, and septic shock. Let's talk more specifically now about the severe sepsis / septic shock core measure. First of all, we're going to talk about who's included in the denominator reporting and then what is required in order to meet the core measure standard for those patients that we're going to be including. So, who is included? First of all, patients who are to be included have to have documentation of the three pillars, and the documentation has to all occur within 6 hours, and that 6 hours has to start at the time of the first element. Now, the three pillars, as we've seen already: documentation of a source of infection, 2 or more manifestations of the systemic inflammatory response syndrome, and then number 3, organ dysfunction. The documentation of a source of infection could be, for example, pneumonia. If you say pneumonia, if the x-ray says pneumonia, if you say severe sepsis, that qualifies. If you say septic shock, that qualifies. But by the way, if you say sepsis, it doesn't, unless you say sepsis due to pneumonia. The second pillar is usually where the 6-hour inclusion clock is started. Usually the patient comes into the ED and one of the vital signs is abnormal. So once the initial vital sign is abnormal, the patient will be included if they meet criteria in the other 2 pillars within the next 6 hours. We've already talked about the SIRS criteria. The third pillar is organ dysfunction, and specifically organ dysfunction in this case generally is met by the return of the result of the serum lactate greater than 2, indicating critical hypoperfusion. But organ perfusion could also mean, organ dysfunction could also mean cardiovascular dysfunction, in other words, hypotension, 1 episode of a blood pressure less than 90, or mean arterial pressure less than 65, or a drop of 40 millimeters of mercury systolic blood pressure within an hour. It could mean kidney dysfunction, acute kidney injury, where the creatinine is greater than 2 in a patient with previously normal creatinine. It could be shock liver, where the bilirubin is greater than 2 in a patient without any history of liver disease. And less commonly, it might be abnormal platelet count or prolonged PT or PTT. Again, all three of these items have to be present within 6 hours. So, for example, a patient with a heart rate of 92 and a systolic blood pressure of 80 at triage, but a normal white count, does not have two service criteria. So they would meet they do not meet the second pillar. So if the respiratory rate was high, but only 6 hours after the triage, and the white count was normal, then the patient would not be included in the core measure. So who's not included? Pretty much everyone you see with severe sepsis will be included. Aunt Tilly, who's 99 years old and is a DNR, is included. People who are not included, those who are less than 18 years of age. Those who are not only DNR but are entered as by you as comfort measures only, they are not included. C. diff is not included. If the patient is a transfer from another facility, they're not included. And then if they expire relatively quickly, within the first few hours, then they can be excluded as well. Now, once we've decided that the patient will be a core measure patient, what do we need to do to make sure that that patient gets the proper care so that they can be reported as in the numerator of receiving the appropriate care? So the core measure assesses documentation of 7 elements: measurement of the serum lactate, obtaining blood cultures, administering broad-spectrum antibiotics, fluid resuscitation, vasopressor administration, reassessment of the volume status and tissue hypoperfusion, and a repeat lactate when the measurement of the initial lactate is greater than 2. Now, of those 7 3 are required in all patients with septic shock. 4 are conditional based upon other factors. But all patients who have severe sepsis, need to have a measurement of a lactate, blood cultures done before the administration of broad-spectrum antibiotics. And all of these items have to be done before 3 hours of the presentation time. So a little bit more specifically, broad-spectrum antibiotic therapy has to be used. So ceftriaxone for urinary tract infection is fine. Metronidazole is not on the list. Cefazolin is not considered broad-spectrum. Vancomycin is not considered broad-spectrum, but if you order vancomycin and aztreonam at the same time, then the time that the initial antibiotic was started will be used as the antibiotic administration start time. If antibiotics have been given within the preceding 24 hours, then that antibiotic can be used as your antibiotic administration time. So those are the three elements that are required in all patients: the lactate, the initial lactate, blood cultures, and broad spectrum antibiotics. Now, for patients that So in addition to the three elements that are required for all patients with severe sepsis and septic shock, there are four other elements that may be required for patients that are sicker. And how those patients are identified, we're going to go into specifically. But the four measures are a repeat lactate, a reassessment of volume status and tissue perfusion, a fluid resuscitation bolus of 30 ml per kilogram, and for some patients that have very severe septic shock, unresponsive to fluids, vasopressor administration. So let's go through each one of those conditional core measure elements that apply, as I said, to only the sicker. Number one, the repeat lactate. So for all patients that have a lactate greater than 2, you're going to have to get a repeat lactate level prior to the 6 window mark after presentation. This is really a tough one to hit, and we're going to talk later, but this is likely going to require some kind of a team approach to be able to hit this particular element. It's a tough one. The interesting thing about the repeat lactate is that it has nothing to do with the fluid bolus. We'll talk about that later. The repeat lactate is merely done for patients with a lactate greater than 2. Now, most patients with a high lactate will benefit from a fluid bolus. Most patients with severe sepsis characterized by hypoperfusion that's critical enough to require to result in a lactate greater than 2 are fluid deficient. And initially, when the core measure was being designed, there was some thought that all patients with severe sepsis should be getting the 30 cc's per kilogram bolus. The Society of Critical Care Medicine backed off that recommendation because some of those patients with severe sepsis, in other words, the lactate levels of 2 to 3.9, came in a bit fluid overloaded. And so the requirement for a repeat lactate for patients that have severe sepsis based upon a lactate 2.0 to 3.9 does not require fluid. It just requires a repeat lactate. But most patients will benefit from fluid, and most patients with severe sepsis benefit even from 30 ml per kilogram. The lactate in general, we're asking you to draw that immediately after the bolus has been given. Or, say, for example, a patient isn't going to get a bolus. Maybe they're going to get furosemide because they're in congestive heart failure. Draw it as soon as the furosemide starts to have an effect. You don't have to wait for 6 hours. As soon as that intervention is complete, even within 30 minutes after the initial lactate was resulted, you can draw another lactate, and that will meet your requirement for the core measure. So why is lactate and repeat lactate included as part of the standard of care for patients with a core measure? So the answer is that, and I never knew this up until this core measure was introduced in June of 2015, that lactate is the most sensitive measure of critical hypoperfusion. Most of these patients, many of the patients may be pink and warm and have a normal blood pressure, and yet they may not be perfusing their peripheral tissues. And the only way to know that is many times because the lactate is elevated. Um, Lactate of 4 or greater is indicative of extremely critical hypoperfusion. In other words, that now has become the CMS definition for septic shock. The reason for the repeat lactate is that if a patient does have hypoperfusion and you blast in that 30 cc's per kilogram and you immediately draw another lactate level, the lactate level will drop like a stone. And so if you've treated the patient effectively, I mean, you're a good doctor, we have good treatments, we're good nurses, we have good antibiotics, that lactate level should go back to normal within as soon as that fluid is given. If the lactate hasn't dropped, what does that mean? It may mean that we've made the wrong diagnosis. Maybe that patient doesn't have a urinary tract infection. Maybe they have an obstructed kidney with UTI. Maybe they don't have a small bowel obstruction. Maybe they have necrotic bowel. So go back and reassess when your lactic acid doesn't go down. Certainly we know that for patients with septic shock, if the lactic acid stays 4 or greater after the 30 cc's per kilogram bolus, that the mortality rate approaches 50%. So that's the first conditional element. The other 3 conditional elements apply to patients with septic shock. Now, the definition of septic shock is very clear in the CMS core measure. Septic shock is either, number 1, a lactate level of greater than or equal to 4, or persistent hypotension. And by persistent hypotension, we mean that in the hour following the completion of the 30 ml per kilogram crystalloid fluid bolus, there has to be one single blood pressure reading that is either systolic less than 90, mean arterial pressure less than 65, or a drop of 40 from the previously recorded. For those patients with septic shock, 2 or sometimes 3 additional elements must be documented. For all patients with septic shock, you have to give them 30 ml per kilogram bolus. For all patients with septic shock, you must reassess the volume and perfusion status after the 30 cc per kilogram bolus is given. And for patients who have septic shock as defined by persistent hypotension, pressors must be started immediately after the 30 cc's per kilogram bolus is given when there's persistent hypotension, but before the end of the 6-hour window. You'll notice that the first element here, the 30 cc per kilogram bolus, is a 3-hour element, and the other 2 are 6-hour elements. You'll also notice that the fluid bolus is a reported element only for patients with septic shock. It's not part of the severe sepsis requirement. So let's go over those last 3 conditional elements one by one. These are the conditional elements for patients with septic shock. The first conditional element is that all patients with septic shock have to receive a 30 cc's per kilogram bolus. It has to be either normal saline or lactated ringer, and generally it should be given very quickly. The Society of Critical Care Medicine recommends that you start 2 large bore IVs and administer that 30 cc's per kilogram for those patients with septic shock over a period of 30 minutes or so. The fluid bolus will have to have been started before the 3-hour presentation time. And a fluid bolus is defined as any fluid that's given at a rate greater than 125 ml per hour Once you write for 125 ml per hour, that fluid, even though it may add up to a larger amount, will not be included in the bolus amount. The second element that's required for patients with septic shock is a clinical reexamination to assess for persistent volume depletion, and that has to be done after the 30 cc's per kilogram bolus is complete. It has to be done by a physician or nurse practitioner or physician assistant. And it has to have a complete documentation stating the time that the 30 cc, and it has to be clear that the 30 ml per kilogram bolus has been completed. It must include the vital signs, and they must be written down. It's not that the vital signs must be part of the medical record. The vital signs have to be included in your note. The cardiopulmonary examination must be done, including lungs and heart. And obviously the reason for this is if the patient's starting to crackle or has neck vein distension, then you're probably not going to give more fluids. Capillary refill, if the capillary refill is less than 2 seconds, then they're they're fluid repleted. If it's greater than 3 seconds, then they're not perfusing their skin well. Maybe they need more fluid. Peripheral pulse evaluation. If the distal pulses are much weaker than the proximal pulses, again, that's going to indicate vasoconstriction. Maybe they need more fluid at that point again. Skin examination. If they're warm and dry, then probably they're perfusing their skin. If they're cool and clammy, it may be that you want to give them more fluid again. So all of those 5 elements, all of those 5 items have to be included in a progress note that is written by the provider after the 30 cc's per kilogram is given, and that has to be for all patients who are given a diagnosis of septic shock. For those patients that have septic shock and have a CVP, there is an alternative way of meeting the assessment for fluid repletion. So for these patients, instead of doing the 5-point clinical examination, the alternative is to do a CVP reading and either a fluid challenge or a passive leg raising. If you do a CVP reading and also a fluid challenge or a passive leg raise, then you will not need to document a clinical reexamination for those patients with septic shock. And the final conditional element for patients with septic shock, as defined in this case by persistent hypotension, is that pressors have to be started within 6 hours, and they should actually be started immediately after a 30 ml per kilogram bolus is complete if there's any persistent hypotension. The newest information that we're getting from Medicare as of January 2016 is that nursing has to document 2 blood pressures within the hour after the 30 cc bolus is complete. Of course, if the patient is hypovolemic by your judgment, certainly in addition to giving norepinephrine, you're also going to continue fluid boluses. So those are the 7 elements for treatment and documentation of patients with severe sepsis and septic shock. Okay, so let's move on to pitfalls in documentation that can occur in the ED and how to make sure that the patients are documented as getting the wonderful care that we know you're providing to them. So first and foremost, you know that the presentation time has to be based on the time that you, as the provider, say that the patient has severe sepsis or pneumonia or a septic shock or urinary tract infection. Now, if the time for your diagnosis is not specified exactly, then the chart abstractors will take the time that the patient was seen by you as the time that the diagnosis was made. That being said, there are many times, I'm sure, that we see patients and there's a delay in returning the CAT scan or the chest x-ray, and so the diagnosis of pneumonia or diverticulitis might be delayed for several hours. And as a result, you may not get the lactate or the antibiotics in until 3 or 4 hours after the patient has arrived. In cases like that, where the diagnosis is made late, we need you to say the diagnosis of severe sepsis or a septic shock was made at, and then state a time. You can do that in your impression when you say pneumonia, diagnosis made at such and such a time, or you can make a separate note in the progress note. But if you specify the time that the diagnosis was made, then the data abstractors will use that specific time as the start time for the presentation. Now, you also have to realize, though, that if you say possible septic shock, then that patient, even if they don't meet criteria for septic shock, even if they don't have SIRS criteria and don't meet criteria even for sepsis, all of a sudden, because you've made the diagnosis of possible septic shock, you're including that patient in the denominator for the core measure report. So that patient now is going to require an initial lactate, is going to require 30 cc's per kilogram, is going to require a perfusion reexamination because of the fact that you've called him septic shock. Other pitfalls in ER documentation. If you say sepsis plus dehydration, that patient won't be included. So when you give that patient wonderful care, you're not going to get credit for it. If you say sepsis plus acute renal failure, that patient won't be included. If you say sepsis unknown source, that patient won't be included. If you say severe sepsis, even if you say severe sepsis unknown source, that patient will be included. If you say sepsis due to pneumonia, that patient will be included. We're asking you to speak the truth. Please don't say SIRS plus pneumonia. Say sepsis due to pneumonia. Please don't say SIRS plus hypotension plus infection. Say severe sepsis due to pneumonia. And please don't say infection plus persistent hypotension or infection plus high lactate. If the lactate is greater than 4 and there's infection and there's SIRS criteria, please say septic shock due to urinary tract infection. So let's talk finally about the barriers to achieving the core measure in the emergency department. We hear a lot from the ED doctors that their patients are too old, too sick, or too big to be able to tolerate that much fluid, meaning especially the 30 ml per kilogram bolus. We have patients naturally now who are 150 kilograms, and in order to meet the core measure, if they have septic shock, they're going to require a 4.5 liter bolus. Well, the truth of the matter is I never gave a 4.5 liter bolus ever, I don't think, in my life. And we're not asking you to do that. What we are asking you to do, however, is for those patients that you're identifying as having septic shock, give them a smaller bolus. Give them 2,500 cc's or 2,000 cc's within 20 minutes or 30 minutes, and then go back and immediately reevaluate them. If their lungs are clear, their neck veins aren't high, and they still have a normal the same saturation, give them another 2 liters. Go back and reassess them in another 30 minutes after that bolus is just being completed. If their lungs are clear, they don't have neck vein distension, their oxygen saturation hasn't changed, then complete the 30 cc's per kilogram bolus. I can assure you that if the patient has septic shock, if they have the high lactate greater than 4 or greater, then those patients have tremendous amount of capillary leak, they have vasodilatation, they have a lot of capillaries, and they have a lot of room to fill. So it would be very unusual for a patient who has septic shock not to be able to tolerate that 30 ml per kilogram. That being said, we will never question your clinical judgment. If you give that certain amount of fluid and it's less than 30 cc's per kilogram and the patient is deteriorating and your clinical judgment is the patient can't tolerate more fluid, then you should not give more fluid. You're the doctor. The 30 cc's per kilogram bolus, however, does come from all of the trials of septic shock, the process trial, the rivers trial, the arise trial. In all of these trials, generally the patients did receive about 30 cc's per kilogram before they were even bolused, before they were even randomized, I should say, to either goal-directed therapy or usual therapy or whatever. Another question that we hear is, my patient has an elevated BNP. Here the issue is that that elevated BNP is a chronically elevated marker and doesn't indicate the current volume status of the patient. So we're going to ask you not to look at the BNP when you're treating patients with septic shock. Finally, if your patient has a lactate of 2 to 3.9, you don't have to really give any fluid to meet the core measure. You just have to repeat the lactate. It's only the patients that have septic shock. Only, in other words, only the patients that have a lactate 4 or greater or persistent hypotension that need the 30 cc per kilogram fluid bolus. That's going to be about 10% of your patients with severe sepsis. It's a small number of people. So, what are the areas of controversy in the core measure? One of the very valid uh, criticisms of hospitalists and ED doctors relates to those patients with cellulitis who are not diabetic. The appropriate treatment in most of these cases is, in fact, vancomycin, which is not considered a broad spectrum antibiotic. Uh, so, in cases such as this, some physicians, if they feel the patient is really that sick, will give vancomycin but also give a dose of ceftriaxone. That would be left to your clinical judgment, certainly. So, how can we as emergency medicine providers hope to get all of those 7 elements, all of those 7 items completed on a patient in our fast-paced emergency departments? What's worked for us at Moses Taylor Hospital is using the team-based approach. Um, we actually have authorized our ED nurses by means of a nursing protocol to begin the identification process of patients with severe sepsis at the triage level. We have a paper-based screen that looks for SIRS criteria and other uh, areas of possible infection. We use the modified early warning system scale, and if the score is 3 or greater, then that triage nurse is authorized to go ahead and get the CBC and BMP and serum lactate ordered and started. In other facilities, the ED doctors will order the initial lactate whenever the initial blood cultures are ordered, and the two orders are tied together in an electronic record. What has worked in our institution is asking the nurses to take the lead in terms of the um, more or less the incident commander for this patient with severe sepsis or septic shock. Most of those patients with severe sepsis are going to be identified because the lactate is elevated greater than 2. And so the system that we have developed is to ask the lab to call any any initial lactate level greater than 2, and that call is received by the ED charge nurse. When that charge nurse receives the call, she has to write it down, he or she has to write it down on a yellow sheet. Number one, they have to inform the provider that the patient may be a core measure patient. Well, maybe the patient has an elevated lactate because they had a seizure and they're not infected. So we're not sure that the patient is a core measure, but the provider has to be aware that if the patient has infection, that this is a core measure patient. If the provider agrees that the patient has possible infection, then the nurse and he should make sure that the blood cultures and antibiotics are ordered. That charge nurse can then go to the patient's nurse and inform the nurse, yes, the doctor does agree that this patient is a core measure patient. He's gone ahead and ordered the blood cultures and the antibiotics, and the blood cultures and antibiotics have to be taken care of promptly by that charge nurse, by the patient nurse. Next, the charge nurse will order the repeat lactate in the system, and the patient nurse will know that once the fluid bolus, if there is a fluid bolus, is given, that that repeat lactate then will need to be done either by the nurse or by the laboratory. The charge nurse will also remind, in the case of the patient has septic shock, in other words, if the lactate is 4 or greater, the charge nurse reminds the provider that the patient needs an order for 30 cc's per kilogram and tells the patient's nurse that 30 cc's per kilogram has to be given as a bolus very quickly on a pressure bag. If the lactate is 4 or greater, the charge nurse also reminds the doctor that a clinical reexamination form or alternatively a CVP reading and fluid bolus will be required once the initial bolus is complete. In our institution, we have a paper clinical reexamination form that the charge nurse will provide for the doctor. Challenges that we've faced, where have been our pitfalls. We've had problems with blood cultures not infrequently being done after antibiotic administration. Initially, there wasn't an order for 30 ml per kilogram. Initially, the paper SIRS screen didn't include abdominal pain or mental status change. And we found that people coming in through the ambulance weren't getting screened for SIRS. So for the last, we actually involved our EMS people in doing the modified early warning system screen and drawing the gray top tube before the patients came into the hospital, and then including that as part of their report. We found that the ED nurses' blood pressures sometimes were not always being recorded in our EMR because we don't have an interface between our monitors and our EMR, and that was a problem for us. And we found that sometimes nursing was hanging the second back of normal saline without scanning it. They weren't aware that the patient was a core measure patient, and sometimes they were treating the patient rather than the documentation. We had pharmacy issues. The barcode on the levofloxacin foil pack wasn't the same as the barcode on the PVC bag, so we had to program in another barcode. We had documentation issues where the 30 ml per kilogram order wasn't printing in the EDM record properly. We had doctors who were searching for the word bolus, and they gave a pediatric order, 20 ml per kilogram of saline. And so we had to do education for our providers to please use the severe sepsis order set that we had built for our providers. We had mechanical issues. Patients who, for example, who are ordered a large volume of saline, but the pumps only go up to 999 ml per hour. So in those cases, we had to educate our nurses and our providers. We want that bolus to go in over 30 minutes. So yeah, put the saline on a pressure bag and get that 30 ml per kilogram in over 30 minutes. Or in some of our facilities have a rapid infuser, and that fluid can go in very quickly in that manner also. Lab issues. Initially, um, when we would repeat the lab within a half an hour, the lab would cancel it automatically because they would interpret that as a repeat. So we had to speak to the lab director. Please don't cancel any of our lactate orders. We are going to be doing frequent repeats. We had a lab normal for our lactate as up to 2.1. And as you know, the severe sepsis cutoff is 2.0, so that anything 2.1 is actually abnormal as far as CMS is concerned. So there was initially some reluctance on the part of the laboratory director to change the normal value and the display in our computer so that a lactate of 2.1 would appear red. After some negotiation and a missed case, he was finally willing to change that. We had residents who were more comfortable giving additional fluid boluses than they were giving norepinephrine. So we had to do education of our residents to start the Levophed as soon as the 30 cc's per kilogram bolus was complete. So what other interventions did we have that we found effective? Number one, we did distribute index cards with the 3 pillars on one side and the 3 required elements for all patients and the 4 conditional elements for the patients with septic shock. Um, is available next to the Pyxis so that when the nurse pulls out norepinephrine out of the Pyxis, that there will be a flag that says, please remember to give the provider this clinical reassessment form and so that that can be completed and included in the part of the permanent record. And we did a significant amount of nursing education. We also had blood culture bans so that the antibiotics would always be given after the blood cultures were administered. This is a printout of what our sepsis order set looks like in the in our electronic record. We also worked with a severe sepsis committee that met weekly and included our core measure abstractors, the ED nurses, and the physician champion and the ED doctors. And we had daily chart audits. We had a new order set built, and mainly we involved nurses to help us in this process.